participants, dear colleague, we are really proud to start our webinar among the continuous scientific series activities in Saudi German hospitals, orthopedic department, as well as other departments in the hospital. I would like to, I'm proud to be the moderator for this webinar. And the subject of this webinar tonight is peri-prosthetic fracture. The addition is that we are going to present some cases and we have our panel to discuss it. It's my pleasure to introduce our Professor Dr. Khalid Batterjee, orthopedic consultant and spine surgeon, head of department in Saudi German Hospital, Jeddah. Our colleague, Dr. Abdelzahir Saati, orthopedic consultant and arthroplasty fellow, and Dr. Ahmed Hadrawy, orthopedic consultant and pediatric orthopedics in Saudi German Hospital, Jeddah. Our today program is to start the two cases we are going to discuss. We're going to give the history, and then we will discuss with the panels what to do for such cases. We will start the first case now. Do you hear me? So, if you can hear me good, so inshallah we will continue. Case number one. This is a 57-year-old female, 93 kilogram, controlled diabetes mellitus, hypertension, and hypothyroid. She gave history of 3 years post-gastric sleeve. 12 years ago, she had an RTA and sustained a fracture right humerus and the femur. He was operated at that time in another hospital with ORIF right humerus, plate and screws. And the distal femur was operated with, as far as we see in the hip arthroplasty and plating of the femur.
Can we share the screen?
Patient presents
shared.
Tenderness and pain on the right humerus and inability to walk due to tenderness in the right femur. Can we see the X-ray, please? Just show the X-rays. This is the X-rays of the femur, and we showed that fixed the plate, the old fixation of the plate, and the humeroplasty. I would like the panel to comment on this, please.
May I comment, Dr. Fadel?
Please, please.
If we can, this patient, first of all, he's an obese patient and had before a sleeve operation, before she had this problem with that. And most of the patients who had sleeve surgery due to morbid obesity, they're really suffering from bone quality after the surgery. This is something that we are noticing these days. So this patient has also a fracture of the humerus, and also a fracture of the neck femur was operated with this tripolar and non-cemented. Apparently, what you can see here, that the fracture of the femur was fixed, and there was between the prosthesis and between the plate, there was a stress point, a weak point. And this is the reason why she had this periprosthetic fracture. In this case, obviously, in my opinion, I don't know if Dr. Saati and Dr. Hadrawy would agree with me that we have to remove the plate and we have to redo it again. The question now, what to do after in this case?
If I may interview Dr. Saati, what classification would you classify this fracture?
Well, first of all, I think after exclusion, of course, the infection, there is no infection. This is, I think, Vancouver, which was, I think, Vancouver type C, which is like, I think if you look closely to the prosthesis, the prosthesis is well fixed, and it's at the fracture is it's coming, as Dr. Khalid said, it's a stress fracture in between the prosthesis and the plate. And if I could make it bigger, I think, the prosthesis is well fixed, solid. It's cemented prosthesis. And it was done like 3 years back, right?
Yeah.
It's not cemented. It's non-cemented.
Is that cemented?
Yes, non-cemented.
Yeah. So if the here, like, if the prosthesis is well fixed, then what I would do, to be honest with you, then I just open again, and I would go ahead with cable plate. So cable plate up there and screws down there. So redo it again. Provided that you have to make sure that the patient is not diabetic, the patient is not smoker, because smoking, affecting the fracture healing, as you know. And if the patient is diabetic, then you have to check the HbA1c, and if it's the patient is diabetic, right?
Yep. Yeah.
Yeah.
Yes.
So you have to control the diabetes status of the patient. And again, the key answer here is for the prosthesis. If it's rock solid, then I would just redo the fracture again. But unless if the prosthesis is loose, then it's something else. Then I go and remove the prosthesis and apply a long stem with the cable plate again.
Yes, for the discussion purpose, Dr. Abdelzahir, how you would decide whether this prosthesis now is loose or not loose?
Well, actually, no, I cannot make it bigger. Here, if you see, I think, first of all, if there any history before that, after the surgery, was she doing very well, like, after the surgery, or was she having any problem? She was walking nicely, right?
No, she was not walking. She
was not walking at all.
She had a humerus fracture, which was she was operated by the humerus, and the humerus, there was also non-union in the humerus.
Okay. Then I think,
let's say she was handicapped with her walking, and this fracture happened, let's say, with a minor trauma.
With a trivial trauma, it's obvious. It's a stress fracture. It's coming in between the prosthesis and the plate.
Yeah.
So if again if you want to do you mean that you want to do a CT scan just to check out that if the prosthesis is loose or not? I think you can check it out, from the X-ray itself. I think it's solid, dude, isn't it?
If you enlarge it, you would see it.
Because look at the other view. The prosthesis here, I think it looks. If it's not solid, they have to exchange it. I put another long stem, cementless, with cable plate again.
Okay, Dr. Hadrawy, you want to comment anything? Why it fractured? Is there a signs possibly of infection, or how would you investigate more?
I think, as my colleague said, that the cause of the fracture is the stress point between the blade and the end of the prosthesis. Agreed with Dr. Saati. The stem looks solid and look fitted well in. There is no signs of any loosening. There is no lines. Although intraoperative, of course, the final decision will be taken. I will go for the replating with very long plate with Codman's wiring in the proximal part, hoping that, as you said, but with patient with more than one fracture, mostly they go in non-union in one of them, and she has already have non-union in the humerus, as the professor said. So I think
Yeah.
that fracture should be addressed as well.
I have to mention here, the femur fracture. This is the first X-ray that the patient came to us in the clinic, and the femur fracture was lower segment, so it is supracondyle, and it was fixed with this plate. But as I said, there was a stress point, a weak point between the prosthesis and the plate. This is the reason why it came again to this peri-prosthetic fracture.
I think one point here, Dr. Khalid, and also for me, just to learn that whenever I am having such a fracture, I should not fix the fracture in that area, because that area is a dangerous area. Actually, that's what's going to happen. So for me and for the other to learn, if I want to fix that fracture, I should go above, like at least like 5 to 8 centimeter above the fracture there, above the plate. So even if the fracture is distal, so I should cross the tip of the plate by at least 8 centimeter there. So because like if you go over the literature, that the vast majority of such a fracture and such fixation is going to break, and always we are learning from the other's mistake.
Well, Dr. Saati, the trauma happened 12 years back, and supracondylar fracture, for me, it looks that they fix it internally with this lateral plate. At the same time, they put the tripolar or bipolar prosthesis proximal. And she went nicely for the last 12 years, but unfortunately, because she had a humerus fracture, so her mobilization was not that strong enough. More or less, if we want to classify here, because this is, if we go to Vancouver classification, just to remind all of us, if it is either Vancouver intraoperative classification or post-operative. And this considered to be post-operative one, which is either the proximal part of the femur, or B, like around the tip of the stem, either with a well-fixed stem, B1, or B2 with a loose stem. And if you have a good bone quality, it is a B2, a loose stem, and if the bone quality, a proximal part is poor, so this is it will be a B3. A C type is the one very distal to the prosthesis. So I think the management will be different, as you mentioned, our colleague here, our panel, according to the stability maybe of the prosthesis. So one of your suggestions, Dr. Saati, you go with the longer plate? Or?
Yeah, again, if the prosthesis is rock solid, I would go for another plate, the cable plate. So cable plate and distal screws with the longer plate, yeah.
You're going to remove this plate and put a longer plate with the cable screw.
Yeah.
Dr. Khalid?
Yes, I do agree with Dr. Saati. I think this is the best solution for this case. As long as the prosthesis is solid and there was no loosening, I would do the same.
Yeah.
Cable plate with the distal, not necessarily all the screws, but this is the best choice for this patient.
Can we show the post-operative, please? What is being done for the case?
Next, yeah. This was just to mention here. We have let's go back. Yeah, for the humerus, this was the non-union part. Now this was too fast.
Yeah,
the non-union part, and this is the continuous of the pre-operative. Just next, please. For the humerus, we have done a vascularized bone graft for the humerus and fixed with the broad DCP. Let's have the next, please. Next.
The humerus. Okay, Dr. Khalid, please. Comment.
This is the humerus, and now please show us the next one.
This is the femur.
Yes, this is the post-operative X-ray with the longer plate and cable plate proximal.
Yeah, good. Looks good.
and bone graft. So we have revised the fracture side. We have put compression on the fracture side and fix it proximally with cable. You could see if you enlarge the X-ray a little bit, you could see the cables, and we have refreshed the edges and put compression on both sides. And we have not used all the screws, alternate to distribute the stress over the plate and the bone.
Did you
Good
add
job.
Dr. Khalid?
Excuse me?
Did you use bone graft?
Yes, we have used bone graft for this case also to enhance, let's say, the union of the patients.
And the stem was well fixed inside.
The stem was well. We have also checked the stem intraoperatively and the cup also, and there was no loosening. It was rock solid.
Good. Well, for the bone graft, you know, if you refresh the edges, like you get the bone graft from the allograft, the one in the hospital, right?
You have used the allografts, from the bone bank.
Okay. Looks good. Good job. Good job, mashallah.
Okay, this is what's been done, and then on April this year, the patient was satisfied for during this time, but unfortunately, she had a minor trauma. And
now, this patient, after this surgery, she was doing fine for the past 3 years.
MashaAllah.
She was walking, she was happy, and we were happy. And then Dr. Fadel, you would continue the history of this patient.
Yes. What happened is that she had presented in the clinic because she was complaining. She was in a wheelchair this time. She has a tender swelling over the right thigh. So we have done the X-ray, and she was really in pain. So this is what shows. Can we see the X-ray, please?
This is what happened.
Oh, wow.
So
this is what happened after 3 years.
Wow.
Yes.
I think she should have lost her kilograms, you know. She's too much obese, eh?
No, she lost. She was doing fine. She was walking, and as she was standing in the kitchen, and you could see there was callus formations. You could see on the medial part of the femur, there was callus formations.
Hadrawy, you want to comment?
Well, there's no infection. No infection.
No infection.
No infection. All right.
What's your comment?
Just a bad luck. Just a bad luck for the patient and for the surgeon as well. And I think now she needs to go for the revision of the stem this time.
Now, this is a real dilemma. This is the real dilemma. The patient, as you said, she had the bad luck, and I was the surgeon. I had the bad luck with her. Now, what is to do?
You know what? It's still, you know, the stem is still rock solid, man. I would, like, you know, if you're going to remove the stem, it's a hell of surgery. You know, now you have to think about something else.
Now, what do you do, Abdelzahir?
Yeah, and you know what? I'm thinking about, you know, double plating, or you can put a bone graft from one side and another plate, like double fixation.
What's a double fixation? You have the stem in your way. There is no place to do a double plating. Anterior or
I have here two options: either to remove the stem. It's a big surgery. Like if you're going to remove the stem, of course, you have to do something what's called extended trochanteric osteotomy, because the stem here is rock solid. You cannot take it very easy. The other option that, you know, you repeat your job again, refresh the edges, you shorten here a little bit, and you can put, you know, from one side the cable plate, and the other side you can put, you know, that, like, you know, the fibular graft, allograft, or you can have, you know, the half of the shaft of the femur. You can put it there, so it will support your fixation.
I can see a comment from my old colleague Tawfiq Mutwalli, he said, change the plate. But what to change? With another plate?
Another
Bone
plate
graft
is not enough. Another
same?
plate. You have to
Only
support
another
it.
plate?
You have to support it with something else on the medial side as well, sir. You know?
This is an option.
You're thinking
Yeah.
about the replating on the lateral and strut on the medial side,
Yeah.
it with cable. So one of the option, and in that case, maybe also you don't have to remove the prosthesis.
Yeah. Because the prosthesis here is still solid, right?
Stem is solid.
Yeah.
And as I said, now the plan, we have multiple options. First of all, replating. Second, double plating. Fibula graft. What about change the stem and make another? Was the discussions between my team. If we do the replating, she will have the same dilemma. The fracture will not unite because this is the third operation at the same time.
Yeah.
So the bone quality is definitely affected. If you do one plate or two plate or whatever, vascularized bone graft, you will have no space to put it in the medulla or attached because the stem is in your way. So the possibilities of failure is very common or is high. So for me, as we have discussed this in the team, I have, you know, that we have an agreement with Mayo Clinic, and they have a huge department, and I have done the revision arthroplasty course in the Mayo Clinic. And what they do in such cases, they do two-stage operations. And the first stage, because it's a very lengthy operations, it needs a meticulous preparations. It's not only remove and replate, because you have to approach and remove everything, including the femur, the shaft, and the cup. So this is not one single operations. So we have planned this in two settings. The first setting is to remove the plate and the screws and the stem, and to prepare for the next surgery, because the revision, the arthroplasty, when you do the revision sets, you have really to be ready for the sizes. You have to evaluate the length of the shaft that you are going to use. So this was a very lengthy operation. So we have planned it in this way. We have removed the stem with the proximal trochanter or femoral or proximal femoral osteotomy, and remove the stem, and then circlage the femur, remove the lower segment also, and then ream the medulla to accommodate a non-cemented long shaft femur prosthesis. Can we have the next one?
Done, Dr. Khalid. How difficult it was to remove the fixed, well fixed stem?
If you have to mention, you have to go, and you have to consider the femur now like a sandwich, and you go from the lateral aspect through the trochanter down to the tip of the shaft of the prosthesis, only from the lateral, and then the medial cortex, you don't ostomize it, you just crack it, and you make you weaken the medial wall of the femur, and then you open the whole femur like a sandwich. And prosthesis, you will find it inside lying, and it is not difficult then to remove. The difficulty was in the first surgery is to to dislocate the proximal part because it's fractured. You understand what I mean? The proximal part is fractured. So to dislocate the cup, and this is a trio cup, to dislocate that cup, it's a ceramic on metal cup. To dislocate it, it was not easy, and the acetabulum cup or the cup was embedded in the bone. So there was huge difficulties if we have to remove the acetabulum cup. This was yes.
Mm-hmm. Good. Can we see the X-ray, please?
Yeah, let us.
See, this is what I meant. We have left the cup, and you could see the proximal part. These cerclage are not due to intraoperative fractures. These are, we call them a prophylactic cerclage. And this is a non-cemented prosthesis with a modular part. The fixed part, which is the lower part, there is another X-ray that shows the shaft, the whole shaft. It goes inside, yes.
Okay.
It goes down. All these cerclage are prophylactic cerclage, so it does not crack. We have to do
you mean there's no fracture there, just to apply these cerclages, yeah?
These cerclage are prophylactic cerclage. They are not due to fractures. Because when you ream, sometimes by revision surgeries, because of the long standing, and you are weakening also the femur, and through when you drill in the femur, it can happen that it cracks.
You have to go up to size 20 sometime.
Yes.
20 millimeter, yeah.
In this patient, we went to 16.
Yeah.
And so these cerclages are prophylactic to avoid cracks, particularly in the distal parts, because these are non-cemented prostheses, and the patient is allowed then to wet bear or partial wet bearing at the beginning. So you could see even the part of the proximal part, the trochanter, still there, and the patient is in our follow-up now for the past 2 months, and she started wet bearing.
Good.
And we are waiting for the next surprise.
خليها تاكل تفة بس ها.
Good.
Yes.
So, any other
We go back, yeah.
Before we finish this case, do you think we can have some questions from the audience there? Graft shaft and the femoral graft.
What was the question, Dr. Fahmy?
It came in chatting. Do you use allograft shaft, femoral graft?
No.
Allograft?
No. This is the patient femur.
And this is a cementless procedure.
This is a cementless 16 millimeter
diameter
femur shaft diameters. The beauty of these prostheses, they are modular. So you have the first part, which is in the medulla. This is a fixed part. If you enlarge it a little bit, you could see a collar. This collar, this is the wet bearing of the prosthesis part. The proximal part of the collar, these are modular. You could see there are two parts, and these two parts are fixed together with one locked screw that prevent loosening, and the neck is mobile, so you can adjust your antivergence and retrovergence in a way that in a way that you test interoperative deflection, extension, and adduction, abduction.
Looks good. Looks good, mashallah. Good.
Thank you very much. Let's hope. So we may move to the second case. You don't mind?
I can see another comments from Dr. Tawfiq Mutwalli.
Okay.
He is asking about the company. There are 3 companies in the market doing these procedures. One of them is Link. I'm not just making advertisement for Link. I am a Link man. The other one is Implant Cast, and the third company is J&J.
And Zimmer too, yeah.
I have no experience with Zimmer, but
Yeah.
these are the 3 companies that we are dealing with. By the way, you have to be very careful with these companies because their representative, they don't have enough experience with these implants because the availability or such cases are not very common. So you have really to plan it pre-operative. It happens to us that the company did not deliver the procedures that we want in one of my patients. I would show it in the later, I hope in another webinar, and we have to postpone the surgery.
Yeah.
Good. I think
So you
just
have
to mind all the audience, all these type of procedures, you have to be sure the minimum diameter of these procedures, because you may not be able to use it in a very thin or small cortex like in Sickler, because I think this procedure started by diameter 14 or something, is it?
Yes, correct, yeah, Dr.
So this is
Fatima.
contraindicated for
Yeah,
Sickler cases.
you have to you have to pre-plan it very well.
Thank you very much, Dr. Khalid. Thank you for the panel. And we start the second case. This is a 62-year-old male, diabetic hypertensive. He had done a left total knee 5 years back, and right total knee was done 2.5 years back in other center here. And then he presented to the clinic with history of 8 months ago. He suffered from periprosthetic fracture in the right femur, and in another center, and it was plated, fixed by plate and screws. 1 month ago, that means 1 month ago after now, before presentation, while walking, he felt a crack and was not able to walk since then. So he presented with this X-ray. Can we see the X-ray, please? So in generally, he's 62, fit, diabetic and hypertensive, no other comorbidities, and he was presented with this X-ray. Dr. Hadrawy, want to comment? We can't hear your voice, Dr. Hadrawy.
The non-union is obvious, and broken blade. I think he need to go for most probably a custom made, because this is an sacrificing prosthesis, looks like. Although there is a hole to go with a retrograde nail, but you need here a compression and to put a lot of bone grafting. I think the best solution for this patient is to have custom implant and to do revision, primary revision prosthesis for the patient.
Dr. Saati, what do you think? Why do you think it broke? It was going nicely.
Yeah, you know what? I think, for such a fracture, if usually what I do, if you have a patient with a fracture like that, to be honest with you, I use double plating. I don't fix it from one side. I have 2 patients. My patient, they have the supracondylar fracture, and I used to fix them with double plating, one on the medial and the other one on the lateral side. I think this is one of the things that she has. Now this patient, she has supracondylar fracture with a fracture of the plate. But, regarding, to do what to do, this is, something else that it depends on, again, the prosthesis, if the prosthesis is solid or not, and that is something, intraoperatively. If the prosthesis is solid,
solid.
probably might go ahead again and apply double plating, you know, if the prosthesis is not solid at that point. But of course, there's one point we have for the audience and for myself. You have to exclude infection, okay, and you know, diabetes, and you know, we have to control it very well. This is the baseline, and then after that, intraoperatively, I go and check it out. If the prosthesis is solid, then I go for double plating and you know, refresh the edges and on the medial and lateral side there. If it's not solid, then I go with Dr. Hadrawy said, the I don't know, the if you can't magnify it.
You can magnify it in the cap.
From
yeah, you just increase the screen. You can magnify.
Yeah. Then at that point, probably custom-made prosthesis. Yeah. Because here, like I've been there, like it's very difficult that you remove this prosthesis and you go ahead for another prosthesis. So I think that's it. Yeah.
Okay, for me, I think if it came to me 8 months ago with the supracondylar fracture, aesthetic fracture, which is proximal to the femur component, after I do some CT scan, and my first choice, I'll go for less plate, less looking plate, if it is possible, and I can reduce it as the colleague done before, I will be good and happy. But why it happened and fractured, I'm not sure if another option was there at that time. Was there another option like a nail, for example, a retrograde nail, Dr. Khalid? Would you do a retrograde nail?
If you go back to the history, Dr. Fadel, this patient has his total knee 2 years ago, and he had a fracture, supracondylar fracture, 1 year. Now he is with this plate and this fixation for 8 months, non-walking. He was desperate. When
after the surgery, you mean? After the surgery?
Yes. He did not walk. This fracture happened also very minor, on a minor. No, sorry. This fracture happened through an accident. Somebody rolled him over. يعني دفه بالسيارة.
Okay.
But the patient was very desperate. Now, again, if we can discuss it, the alternatives, what to do. Now, if you look really carefully to this fracture, it is directly supracondylar. There is no enough space between the condyle and the femur and the lower femur shaft. So apparently and definitely, يسموه بالألمان ده العزم يعني اللي هو
the moment term.
ايش يسموه؟
moment term.
شكرا. The moment term between the supracondylar and the femur shaft is very weak. So it will lead definitely to the stress fracture, even with major trauma or with less trauma. It will not be united. Now you have an option. Remove the plate and screws, do double plating. I had an option also for vascularized double fibular graft. I have an option for retrograde nail. We have discussed this with the patient. And you know, the answer of the patient said, I want to walk. I don't want other alternatives. I was not walking for the past 1 year. And I want to walk, doctor.
Yeah, that's the best answer, yeah.
Now, all these alternatives will not give him the option of walking. If you do double plating, if you do vascularized bone graft, if you do nailing, you will have the possibilities of non-union again. So for me was distal femur replacement. And intraoperative, we have found that the femur shaft, the femur prosthesis is solid. Also the tibia is solid. Now, to decide how far you go, you have to do a CT scan. And I don't know whether we have the CT scan on these patients or not. Yeah, if you could see, I don't know, is it clear? we have more cuts on the CT scan, or this is the only cuts? Yeah, if you could see on the corona, on the sagittal view, the distal femur is very small. It's the prosthesis is almost in the line of the fracture. So interoperative, it was confirmed that the femur condyle of the prosthesis, the fracture was exactly there. So the possibilities of non-union, if we do the alternative treatment, was not good. So the alternative was to do a distal femur condyle replacement.
You mean it was it was just the supracondylar fracture, but this is a revision now, right? I totally agree with you because it's a revision. So we go now towards something else, which is like we customize our knee here, right?
Yeah. Yes.
Yeah. But you know, if I go from the beginning, like if this patient came to me from the beginning, like I wouldn't like the locked plate. To be honest with you, Professor McKee et al., the group in the States, then they disagree completely for the locked plate. And that's a problem, the locked plate. So they said that if you want to apply a locked plate, you have to apply another plate from the medial side. Because the failure rate is very high.
Why locked plate is not good? Why?
You know, to be honest with you, there's a lot of a lot of studies, from the AOS in the States. The locked plate, especially in the weight-bearing area, in the lower extremity, in the weight-bearing area, especially in the distal femur, it's a very high. Unless if you have a patient with low demand, he's not full weight-bearing, he's not he's having a problem. But usually, to be honest with you, for a patient with walking, his ambulatory, I would go for double plating.
Primarily,
yeah.
The first option for you is double plating, so medial and lateral plates.
Yep.
If it is a fracture, and it depends on the location of the fracture, especially if it is very low supracondylar.
Yeah, again, Dr. Fadel, the prosthesis, if it's rock solid.
Good.
Of course, Vancouver or Baz Al-Masri, he did not make this classification for the knee. He made it also only for the hip. But we're using almost pretty the same classification here.
Good. So your decision will depend on the location of the fracture, the site of the fracture itself, the quality of the bone around the fracture.
Yep.
If it is well fixed or it is loose.
Yep. If it's well fixed or loose, or the bone quality as well. If the low bone quality or the fracture is loose, at that point, as I do, as Dr. Khalid he did, I customize my knee. Yeah.
This is why was that, Dr. Khalid, right?
I would agree, Dr. Abdelzahir. If the patient come the first time with a periprosthetic fracture, I must give him a chance.
Yeah.
مو على طول أعمل له customized prosthesis. Medial and lateral is the best option in this terms, even with a lot of screws and plates. This is the maximum security I can give you. If it failed also after that, that means we have to do it then custom made.
That's his luck.
That's زي ما قال دكتور حضراوي, يعني he's a bad luck.
Yeah.
Okay.
Good. So let's see what is being done, please. Slide. This is the CT scan, and it was proved, as you said, confirmed that the fracture location was very close, low supracondylar, we can say, or just at the tip of the femoral component.
Yeah, exactly.
What was the quality of the bone, Dr. Khalid?
I would say the patient was he was 62 years old. He was not bad. This is the intraoperative. Interoperative. On the left side, you could see. Now, when you do this, the question is, on the right side, you see the block. We have not done any osteotomy. We have only removed the condyle total, and you could see if you enlarge it, you see the fracture is exactly on the edge of the condyle. And the plate, this was the plate, and the liner, and the tibia part was solid fixed. Now, if you go more on the left, if you from the screen, these are the trials. Now, this prosthesis is a very unique. In these prosthesis, this is link prosthesis. It has a fixed solid part, non-cemented again, of the femur, and the condyle is locked with the tibia. So
Hinged knee.
It is a hinged rotational knee.
Yeah.
So it is one part, but it is rotational. So there is an axis between the femur and tibia. You could see it here, the metal between these two green, the inlay and the femur. And in between, the next picture, it shows the polyethylene part. This is a non-weight bearing. The weight bearing is mainly on the inside axis. So the patient is really allowed to weight bear from the first day. So this
Weight
is
bearing,
a
that's really, yeah.
Yes, it is a non-cemented part. Now, you could see, because unluckily the patient had his fracture and approach was lateral, we had to go in the same incision, and I had to do an osteo to expose the femur without avulsion of the tibial insertions of the quadriceps. I have to ostomize the tubercle tibia and then fix it with 2 screws.
This will give you much exposure, and you can expose all the areas there, and then the fixation will be nice.
Yeah, it can give much better exposure to the whole femur shaft. And this is a one setting procedure.
Yeah.
It's not, we have not done in 2 settings. There is a video film. I think there is a video clip. Yes. This is an interoperative testing of stability, and then after we done the definite prosthesis and reposition the quadriceps, again, this is just only testing that everything is fine. And this is the post-operative. As I said, the patient is still in the follow-up, and he has passed now the 2 months, and so far he's doing fine.
Good.
He's walking, and inshallah he will enjoy his.
Good job you've done, Dr. Khalid. I think rocking the wood, you know. Good job, mashallah. Yeah.
يعني ايه rocking the wood يعني معناها.
امسك الخشب. Good job, mashallah. You know, you get orgasm. You remember the orgasm? By the way, I was a resident with Dr. Khalid.
Abdelzahir, احنا on live. احنا live.
Good job, والله Dr. Khalid. That's a good case.
Some comment from the audience. Our colleague, you are free to send your questions or comments on the chatting, and we are really proud of answering them. Thank you, Dr. Khalid, for the good job here, and we just wait for some questions or any other comment from the colleague. Yasir, did you receive any chatting from you in your side?
We have some audience want to participate. Dr. Ihab is raising his hand. We can allow him.
Yeah, sure.
Dr. Ihab, unmute and talk, please.
بشكر حضراتكم على المحاضرة الجميلة والمثمرة ديت. والله احنا استفدنا منها جدا، وبشكر دكتور خالد جدا. وبس انا كنت يعني سعيد ان انا انضميت لحضراتكم بالمحاضرة الجميلة دي.
شكرا يا دكتور إيهاب. حضرتك في السعودية ولا في مصر؟
لا، في مصر.
اهلا بيك.
اهلا وسهلا يا فندم.
احنا الويبينار قربنا كتير وبعدنا عن مصر للاسف، الواحد
والله
محبوس
احنا
هنا.
دكتور خالد مفتقدين حضرتك جدا.
دكتور
الحالات
سليمان
الجميله دي كنا بنشوفها مع حضرتك في السعودي الالماني، وكنا بنتشرف بحضرتك، بس يعني الكورونا بقى بعدتنا.
ان شاء الله ان شاء الله نشوفكم عن قريب باذن الله.
Dr. Suleiman also has a comment. You can please.
السلام عليكم، مساء الخير. تشرفت بكم سعادة الدكاترة. حاليا في ألمانيا. great job دكتور خالد، صراحة difficult case بس I am proud of you، يعني great job في الني. شكرا.
I have to mention يا دكتور سلمان, this is not my job, this is a teamwork, and I have يعني دكتور ساعات والدكتور فاضل والدكتور حضراوي, this is part of the team. I never do these cases alone. We discuss the case in details and we plan it also in details and then we make a common decision. I'm just
ما شاء الله.
sometimes زي ما يقولوا ايش كبيرهم فقط اللي علمهم السحر.
كذا تشجعونا اننا نرجع بحماس ونستفيد من خبراتكم ما شاء الله، مع العلم اللي اخذناه هنا، ونستفيد بآرائكم واجتماعكم المثمر ان شاء الله.
ان شاء الله دكتور سليمان، فرصه سعيده.
شكرا.
عندنا
تفضل.
فين في المانيا دكتور سليمان انت؟
في ميونخ ان شاء الله.
ما شاء الله. انا ولدي حيدرس السنه الجايه طب عندكم في ميونخ.
حيا والله ان شاء الله ينور.
ايوه في احد معانا ثاني؟
كان في سؤال من الدكتورة فوزية، تعتقد ان الفيتامين دي deficiency because she was obese and did for the first case.
والله this is a good point. We have not looked at it يا دكتورة فوزية. يعني I think we should analyze this vitamin deficiency because the first patient she has also a humerus fracture and she went also in non-union.
Yes, Dr.
Thank you.
Thank you very much for this comment. In fact, I was about to add some notes about the medical treatment. In fact, so for these multiple fractures, osteoporotic fractures, they always now mention fix and treat, and it's not only fix and treat. We are keeping this in mind. We have to go for some osteoporotic investigations and then further medications. Just recently, I think last night there was a webinar on fix and treat regarding the osteoporotic fractures, and we always advise that you have to start with some teriparatide or denosumab as for the osteoporosis. So it goes parallel. It should the treatment what it advise, it goes parallel regarding the surgery and the medical treatment, and this is what's been advised in the last time. So I hope, I don't know, Dr. Khalid, if we are doing routinely for these old patients DEXA exam or at least osteoporotic investigations before even or during the therapy, and then we recommend them to use the anti-resorptive medications.
Frankly speaking, not in the periprosthetic fracture, but in the trauma, yes. In the elderly patients with trochanteric fractures or osteoporotic fracture in the spine, yes. Good. We do the periprosthetic treatment and we check the vitamin D.
Yeah, good. Any more comment from the panel?
كان في سؤال عن في the second case about should we go for double plating and bone grafting as routine in such fractures, since second operation would be custom-made prosthesis.
Okay, so Saati?
Yeah, I think we said that, like, we don't customize our knee from the beginning. If you have a fracture, if you have the same patient come, like the same patient came to me from the beginning, yeah, I would go for a double plating, provided that, the prosthesis is solid. If she has a bad luck, then at that point, I would think about something else. But I don't go from custom-made prosthesis from the beginning. Yeah, he's right.
Do you think there is an indication of retrograde nail in such periprosthetic fracture?
السيد قال الكلام هذا حضراوي. You have said this.
Yes, I think first we should think about the retrograde nailing rather than saying routine double plating. There is nothing in medicine called routine, especially it depends on what you are faced intraoperative. The good planning is the must, and I think for these fractures we should go first. Thinking first about retrograde nailing if the prosthesis allowed that. Otherwise, yes, double plating is the best option.
But
just to mention, yeah, Dr. Hadrawy, we have thought about retrograde nailing, but we did not know this prosthesis was sacrificed or not. But I had the nail was ready. As I said, pre-operative planning is very important.
Excellent.
Very important.
Yeah.
So we had plating ready. We had the fibula graft was ready. Also the retrograde nail was ready. But then intraoperative, we have said, okay, we have to go for this.
For the retrograde nailing, one comment. For the retrograde nailing, as Dr. Khalid said, if you have the cruciate retaining nail, the cruciate retaining knee, yes. But this is a PS, posterior, posterior civilized knee.
Even there is a hole.
Yeah, but you cannot, what?
Size 11. It will take size 11.
My experience in that hole, it could not allow you to go and put the nail through. I've been there.
There was a hole. We could put the nail.
Yeah, it is designed for that. And here I think I will take an opportunity just to say for our junior audience, here for such cases, you shouldn't do such cases in a small institutes. You should do it in a very well prepared center with a very good experience, and you should be ready with all options for your what you are going to face and what you are going to do. As the professor said, the nail was there, the plate was there, the customized prosthesis was there. So you shouldn't go unless you have everything in your hand. So you will not be faced with any surprises intraoperative.
Yeah. You should have open-minded, so discuss the case very well, as Dr. Khalid what he did, and then you go there. Yeah.
Even that sometimes you face surprise.
I think maybe it is a better option if it is the fracture is a little bit higher, Dr. Khalid, right? Because the fracture side, the location of the fracture, if it is just close to the prosthesis or very, very far distal, you cannot even hold the locking screws in the distal.
That's the reason we went to.
So this is why the reason that you did. I think it's that was the best option. Also.
Yes.
Very nice.
كان في الدكتور كامل البوري تحب تكومنت دكتور كامل؟
السلام عليكم جميعا.
عليكم السلام.
يعطيكم العافية على المؤتمر هذا اللطيف. أنا سؤالي ما أدري في أحد من الأخوان الأساتذة كذلك he face like these fractures with sickle cell disease patient. The bone quality in sickle cell disease patient is little bit different than the normal one.
Yeah,
it is
exactly.
So what you advise regarding this peri-prosthetic fracture, like first case with the hip with a stable stem again, but he has sclerotic, because sickle cell disease patient, they usually have very sclerotic bone.
Yeah,
and the blood supply. So I need your advice.
In sickle cell peri-prosthetic fracture, I go for customized. I don't go for another chance for union or non-union. Yeah. They tend to be non-united.
Yes.
So I
completely agree. Yes.
Yeah. We go for the direct customized procedure.
Dr. Khalid, I think here in Dammam, we will have a lot of cases, vascular necrosis, hip and shoulder. So I think
Yes.
we will need your help and your experience in that. Yani let's the flow become more and more here in our hospital. We will need your help in this.
Well, I am ready. If you have, my team can fly anytime. We have shifted from bringing the patient to the hospital to bringing the doctors to the hospitals.
We need your own experience, Doctor.
Anytime, doctor, anytime. But as I said, AVN is an endemic in areas. يعني عندنا احنا السيكلرز mainly غالبيتهم عندنا في الشرقية وفي المناطق الجنوبية. يعني فدي يعني زي ما يقولوا epidemic areas where the sicklers are very common.
Exactly, صحيح. وإحنا we have really a lot of patients with hip vascular necrosis here and a lot of complication, even the infection because they are immunocompromised and as you said,
exactly.
also the blood supply. So a lot of infection post-operative we are facing. So again, it is really good practice to have here and service of excellence here in our hospital. So this is one of my goal here in our hospital here to have it inshallah.
Thank you دكتور كامل. انت في اي هوسبيتال دكتور؟
الدمام.
السعودي الالماني.
اي نعم السعودي الالماني الدمام.
مرحبا دكتور. انا بقول في اي مستشفى كده انا I don't know it.
قابلنا مرتين دكتور من قبل في ايام الحظر وايام الكورونا في ويبينار.
الله يحييك يا دكتور.
الله يسلمك ويسلمك ان شاء الله دكتور.
كامل احنا حقيقة we had يعني we can say a good experience in our hospital, King Fahd Hospital Jeddah before. I used to treat many of sickler coming from other areas from the south.
Okay.
And I used to do them for them. I started by resurfacing for a couple of years. Maybe 8 years, and we have done a lot of cases of resurfacing because always the problems intraoperative. You have to prepare your sickler patient very well. You have to rehydrate them first.
Exactly. Yeah.
It's the teamwork. It's the anesthesia. It's the hematologist, and then it comes to you as an orthopedic surgeon. And we did many cases. We're still doing cases. The difficulties, remember, in the narrowing medulla. And
exactly. Yes.
For a reaming, you will take a long time for reaming. The morbidity is high, but still you have to treat them. So recently we have done a sickler one with a cementless. You have to take the smallest stem as much as you can. If it is strong enough, if you take a longer stem, it will be also much better. A lot of studies came. Some of that studies came. The first studies came with sickler in our area, in the Gulf area, was from Bahrain, and from Musa we presented in G&G journal, JBJS that time with all complications. 50% was the mortality rate because of the bleeding, and it was not much preparation was not
prepared.
Some of them there was an infection, but after that, alhamdulillah, the improvement was very obvious, and I think a lot of experience our colleague they have done. And what is the latest indication is go directly for a cementless total hip prosthesis. You agree, Dr. Saati?
Yeah, actually, I've done when I was at Al Noor Hospital there. I've done a lot, a few cases actually, probably 5 or 6 cases. They came from southern part of Saudi Arabia. I think the Najran, they're like a sickler. Usually, I used to use the cementless small stem, which is number 1, and the canal usually 5 or 6 millimeter diameter. And the cup always, is a cementless cup. And you should prepare your patient very well, give the antibiotic, as usual, and try to make your surgery as quick as possible. And they're doing very good job till now. But it's still like, as Dr. Fadel Abdeen, he said that, you could go with cementless straight, small stem.
Usually also you have...
Which is usually, I think, if it's not available, you should call a company and you ask them that it's a sickler patient and you should get a small stem type number 1 or number 4. I mean the small stem.
Because usually they have very, very small medulla.
Yeah,
So,
you're right.
this is exactly. And also we usually do as you mentioned, we have teamwork here for preparation, starting from internal medicine, hematologist, anesthesia, dietitian, rehabilitation, orthopedic, all we form a team for pre-op evaluation and preparation.
Thank you, Dr. Kamil. I think we'll keep in mind that we will consider this in the next hour series, Dr. Khalid. I think in our continuous scientific series activities to keep some common problems in our area and our experience in this field. Inshallah.
Nice idea. Inshallah. يعطيكم العافية.
Thank you.
اعتقد الاسئله خلصت دكتور فاضل. We can conclude بعد اذنك.
We conclude. Thank you very much. I thank the panel for the comprehensive and complete explanation for the nice cases presentation, Dr. Khalid. Remember, we have to our audience, we do have the feedback form. It will be sent to you after we close the meeting, and the CME hour is considered 1 hour. Hope to see you, inshallah, in the future with more webinar and scientific activities from Saudi German Hospital in Jeddah or other areas, inshallah. Thank you, Dr. Yasser. Thank you, Heidi. Thank you.
Thank you very much.
Thank you.
Thank you and good night.
Thanks.
Okay, you may leave the session, please.
مسجل معاكم يبان. ايش سويت يا نورة؟
اوكي. شكرا دكتور ياسر.
شكرا دكتور فاضل. شكرا دكتور احمد. شكرا نورتونا. شكرا جزيلا.
شكرا جزيلا. الله يسعدك.
مع السلامه دكتور. مع السلامه.